Hello and welcome to Vibrant Wellness. Our webinar today is the saliva hormone test, a deep dive. This webinar will take an extended look at the analytes of this test and explore its clinical relevancy in a variety of conditions and address the question, how can the saliva hormone test benefit your patients? My name is Deb Harding and I'm your presenter today. I'm a naturopathic doctor with over 20 years experience in clinical patient care, and I'm an education specialist here at Vibrant Wellness. What are the main strengths of saliva hormone testing? I'll summarize 3 main points of them, although there are a few others on the slide. The first main point is that if your patient is suffering from hormone-related symptoms related to estrogen, progesterone, or androgen deficiency or excess, salivary testing provides a unique look at bioavailable hormone concentrations that are active in the tissues. These results may differ slightly from serum or urine levels as they are an alternate lens to view the hormone picture with. Second, if you suspect your patient has ill effects from long-standing stress or glucocorticoid challenges or HPA axis dysregulation, the salivary hormone test provides a comprehensive look at adrenal output by measuring cortisol and cortisone 4 times throughout the day and charting the results in a diurnal graph. And there is research-based efficacy in adrenal cortisol monitoring, including use of saliva in diagnosis of Cushing's disease. Third, if the patient is on topical hormones or transdermal hormones, salivary hormone testing is a preferred method to follow administration of these hormones, as it can capture hormone that's not typically captured through other test methodologies. The types of patients that benefit from salivary hormone testing are those you suspect of having sex steroid hormone imbalances or HPA axis imbalances. On the left, you'll see a list of symptoms relating to estrogen, progesterone, and androgens. And on the right, you'll see symptoms that are related more to HPA axis imbalances, and these are issues like chronic fatigue, dysglycemia, thyroid, mood, and depression symptoms. Vibrant uses LC-MS-MS exclusively as the methodology for salivary hormone testing. This is a newer type of testing method compared to previous types of salivary hormone testing, which used largely immunoassay. LC-MS-MS has higher specificity and can measure lower levels of hormones. Estrogen levels in menopause can be very low in saliva, for example. However, they can be measured with this type of testing. Here is a list of the test analytes on Vibrant Saliva Test. You can see that we offer 3 different estrogens in the salivary sample, and that enables us to give an estriol ratio. We also offer a progesterone estradiol ratio in that list. And for the glucocorticoid section, we offer cortisol and cortisone 4 times a day, so we can chart a diurnal pattern, as seen here. So let's start at the beginning of the test analytes. First thing you'll notice is that, again, there's a lot of estrogens on this panel. Here we have the estradiol, estrone, estriol, and the E3 over the sum of E1 and 2 ratio. Let's start off with estradiol, our strongest and most biologically active estrogen in circulation in males and premenopausal females. It's also the strongest estrogen, about 80 times more potent than estriol, the weakest estrogen. And estradiol plays a key role in many things. It's most notable for its development of the female reproductive system, including breast development, but it also has non-reproductive roles in cognition and neuroprotection, lipid and glucose homeostasis, adipose distribution, cardiovascular health, pancreatic cell function, bone maintenance, and wound healing. Estradiol originates from cholesterol, which is converted through a cascade of progesterone and androgen intermediates, and finally results in estradiol through aromatization, here from testosterone. And in a premenopausal woman, this occurs primarily in the ovary, whereas in a postmenopausal woman, estradiol is sourced directly from the peripheral tissues, predominantly from estrone, sourced from adrenal precursors and converted through aromatization and 17-beta-HSD activity. In a postmenopausal woman, the estradiol primarily acts locally and affects structures in a paracrine or an endocrine manner, and systemic estradiol results from circulating estradiol spilling over from these local areas. Now let's shift our attention to estrone, or E1, which is a weaker estrogen than estradiol, and in fact, by some estimates, it has less than 10% the strength of E2. And interestingly, levels of estrone don't differ significantly in a premenopausal woman versus a postmenopausal woman, but estrone is the predominant estrogen in a postmenopausal woman by a factor of about 100-fold compared to estradiol, and that's largely related to the drop-off in estradiol in the menopause transition. Estrone has similar correlations to estradiol in a postmenopausal woman in that E1 concentrations have been positively correlated with bone mineral density and breast cancer risk, and E1 concentrations are inversely correlated with colon cancer risk. Serum estrone levels are an important indicator of serum estradiol levels in a postmenopausal woman. Like all estrogens, estrone originates from cholesterol and subsequent progesterone and androgen intermediates, and specifically, estrone is derived from the conversion of androstenedione by aromatase enzyme found in peripheral and adipose tissues, and estrone can be converted to small amounts of estradiol in peripheral tissues. Rounding out our trio of estrogens is estriol, or E3, the weakest of the three estrogens. It's presumed to be much weaker in activity because it dissociates very rapidly from the estrogen receptors. And classically, we know the most about estriol and its role as the predominant estrogen of pregnancy. It has functions there of regulation of uterine and placental blood flow and placental vascularization. Lab testing for estriol has most been used as a maternal screening for fetal anomalies. In the last few decades, E3 has been used as a hormone off-label for menopausal symptoms such as hot flashes, vaginal atrophy, and bone density. It's also been studied in the research for immunomodulation benefit and neuroprotection in multiple sclerosis and protection from atherosclerosis. E3 is made, like other estrogens, originally from cholesterol and androgen intermediates. We see here that estradiol is reversibly oxidized to estrone, and most estriol is formed from estrone via CYP3A4 metabolism and 17-beta-HSD activity. Also, both E2 and E1 can be irreversibly converted to estriol in the liver. And once you have your patient's test results, the next thing you want to know is what's the cause of an irregular value? And sometimes that's really easy to see. For example, when a patient has high estrogen and they're taking bioidentical HRT, and it logically follows that that's the cause of it. Or when they have low estrogen and they have menopause or oophorectomy or aromatase inhibitor drug that they're on. Then you can say, oh, that makes a lot of sense. Of course, that's why. But other causes aren't so clear if those scenarios aren't the ones that are active in your patient. So let's look at some other reasons. We see here under high estrogens, it lists excess aromatase activity, and that can happen for a variety of reasons. These listed on this next bullet point can all cause an increase in aromatase activity, and that's age, obesity, insulin, gonadotropin use, or alcohol use. Also, inflammation in general can cause excess aromatase activity. And one mechanism is that inflammatory triggers can cause a decreased pH, and that can lead to activation of aromatase enzyme. Other things listed here are chronic liver disease, hyperthyroid, dysregulated gut microbiome, which we're going to get to in a few slides down the road, pregnancy or ectopic production from a tumor source. So those are all things to rule out for your patient or explore when it's sort of an unexplained cause of high estrogen. Conversely, low estrogens, um, the most obvious culprits and the most common culprits are here. But aromatase inhibition can happen, and that is very common with very commonly prescribed drugs. It also is common with some pollutants. And so I'm just going to give a little list here of some drugs or toxicants which can increase aromatase inhibition. And so obviously aromatase inhibitors for breast cancer use most commonly will cause that, but also antimalarials and immunosuppressive drugs like glucocorticosteroids and methotrexate. The pollutants that commonly can cause aromatase inhibition are herbicides like glyphosates and Roundup, as well as agricultural antifungals, and then cigarette smoke. And also, just increased NSAIDs can cause it. Increasing prolactin, it says here usually drugs or pregnancy, postpartum, and some of the drugs that are linked with this are very commonly used drugs. So things like antidepressants, antipsychotics, anticonvulsants, opiates, estrogens, antiandrogens, antihypertensive drugs, and H2 receptor antagonists. And so those are some things that you can look for when the results are not explained by obvious factors. Next, we move on to progesterone and progesterone to estradiol ratio. Moving on to progesterone, some researchers have postulated that life is not possible without progesterone due to its critical role in multiple systems, and I think they make a good case for it. It's a fascinating hormone. Firstly, we know that it has an important role in menstruating women, and also in implantation, and also in pregnancy. So just to unpack that a little, in a menstruating woman after monthly ovulation, the corpus luteum in the ovary produces progesterone, which halts endometrial growth and induces secretory changes in the uterine lining to promote successful implantation. Withdrawal of progesterone is associated with the onset of menses, and progesterone has vital roles on breast development and during pregnancy and lactation. In men, progesterone influences the formation of sperm and testosterone in the Leydig cells. And in men and women, progesterone plays a vital role as a precursor to critical steroid hormones. And we can see here that progesterone is formed from cholesterol, and that gets converted through CYP metabolism to pregnenolone, and through enzymatic conversion from pregnenolone to progesterone. From progesterone, it is the precursor to hormones such as aldosterone, cortisol, testosterone, and estradiol. Functionally, progesterone has important roles in cardiovascular, renal, and musculoskeletal systems, and further, it's a neuroprotectant, a neuromodulator, and aids with sleep. Lastly, progesterone plays a role in immune support and cancer protection against endometrial, colorectal cancers, and potentially others. Once you have your progesterone and your estradiol values, it's easy to get a progesterone to estradiol ratio, as we have on the test. Conventionally, the PG to E2 ratio has been used in infertility, specifically IVF research for pregnancy rates. It has also been studied a little bit for characteristics of menstrual cycles and fibrocystic breast conditions. But more commonly, we've heard of it the last few decades as it's used empirically as a marker of estrogen dominance, and that's a term that's been popularized by the late medical doctor John Lee and his writings. An elevated PG to E2 ratio is less common. We'll start with that one here at the bottom. And that can be caused by exogenous progesterone use or increased endogenous progesterone production, like you would see in pregnancy, or decreased estradiol production. So basically, when the ratio is increasing, or increased, you're saying that the progesterone is high relative to the estradiol. More commonly, what you tend to see is a decreased PGD2 ratio, and that is the value that's empirically considered the marker of estrogen dominance, and this is where your progesterone level is low relative to your estradiol. And this can be caused naturally by perimenopausal reductions in progesterone, which precede reductions in estradiol. It can also occur later in menopause and andropause with natural aging and reduced progesterone levels. And additionally, a decreased PGDE2 ratio can reflect suboptimal clearance of estradiol and or estradiol metabolites related to metabolic health conditions, impaired detox pathways, and or environmental xenoestrogen exposure. And now we'll move into the androgen analytes, testosterone and DHEAS. Now we'll turn our attention to testosterone, the predominant androgen in men and women. The benefit of salivary testosterone is that it is consistent with serum-free testosterone rather than total testosterone levels. And the total testosterone is often influenced by sex hormone binding globulin levels, and they can fluctuate by numerous systemic conditions. So in testing a result of free and bioavailable hormone, such as in the saliva test, you're removing that fluctuating variable of the sex hormone binding globulin. Testosterone is produced primarily by the gonads, the testes and the ovaries in men and women. Secondarily, it's produced by the adrenal glands, and the main precursor is DHEA, you can see here, and it's converted to androstenedione or androstenediol, and then through enzymatic conversion results in testosterone. Functionally, testosterone has a reproductive effect and an anabolic effect in that testosterone supports reproductive function and libido, but also helps maintain red blood cells, muscle mass, and bone structure. Testosterone also supports cardiac health and promotes optimal brain function. In males, we know that testosterone promotes the development of male sex organs and secondary sex characteristics, such as deep voice, body hair, and libido. In females, testosterone is produced by ovarian production as well as adrenal secretion. And in advancing age, the ovarian production of testosterone decreases gradually throughout age rather than suddenly in a menopause transition. Nonetheless, by menopause, the total testosterone levels in women aged 65 to 74 years old is approximately 1/3 that level observed in women who are aged 20 years. And similarly, in men, the levels wane of testosterone gradually rather than suddenly, beginning at about the 4th decade of life. The second androgen we measure is DHEAS. The most common question we get is, how does DHEAS differ from DHEA? DHEAS is the sulfated version of DHEA. It's also the most abundant version, and compared to DHEA, it has a longer half-life, and it doesn't have diurnal variation throughout the day, and for those reasons, it provides a stable pool of circulating hormone from which to measure adrenal androgen activity. By itself, DHEA and DHEAS are just slightly androgenic, but they do serve a very important purpose of being a precursor to androgens and estrogen in the periphery. Effects of DHEAS are that it's known to be a buffer from the effects of glucocorticoids and from oxidation. It's also known to be a neurosteroid. Typically, females are referred for evaluation of DHEAS for virilization or masculinizing symptoms or PCOS evaluation. They also referred for DHEAS testing for adrenal issues that are suspected, like adrenal insufficiency, adrenal tumor, or congenital adrenal hyperplasia. They can also be referred for uncontrolled hypertension and alopecia. DHEAS, like all steroid hormones, begins with the conversion of cholesterol into pregnenolone. And from pregnenolone, it's converted to 17-OH pregnenolone, goes through some enzymatic conversions to either 17-OH progesterone or to DHEA. The sulfation of DHEA into DHEAS is catalyzed by HST or SULT2A It's the enzyme hydroxysteroid sulfosyltransferase. And DHEAS can be converted back into DHEA by the steroid sulfatase. Now we'll move on to some causes of elevated androgens. DHEAS and testosterone can be mildly elevated for idiopathic reasons. Other considerations include, of course, exogenous supplementation of either androgen, elevated cortisol, PCOS, precocious puberty, congenital adrenal hyperplasia, steroid sulfatase deficiency, androgen secreting adrenal tumor, or, as we discussed, pollutant exposure or drugs, as well as other causes. There are numerous potential causes of decreased androgens. Here's a list of contributors to either decreased DHEAS or testosterone. Biological aging in males and females is probably the #1 cause. However, chronic stress, chronic inflammation, primary or secondary adrenal insufficiency, hypothyroidism, increased body mass, they can all play a role in reduced androgen production. Many drugs can contribute to this also, so you always want to run down any drugs the patient's on to rule that out as a contributor, as well as some other less common things that are listed here. Next, we're moving into the adrenal section of the saliva hormone test with the glucocorticoids, cortisone and cortisol. And this slide shows an image of the adrenal cortex section of the adrenal gland where they are produced in the zona fasciculata. Cortisol is widely known as the stress hormone, and nearly all tissues in the body have glucocorticoid receptors to respond to the actions of cortisol. It plays a significant role in maintaining glucose and protein homeostasis, mediation of the stress and immune responses, and suppression of inflammation. In tissues, the glucocorticoids are regulated by 11-beta hydroxysteroid dehydrogenases type 1 and 2, which we'll get further into in subsequent slides. The hypothalamus pituitary adrenal axis, also known as the HPA axis, regulates the production and secretion of cortisol, and that begins when a stressor activates the hypothalamus in the brain. And this area is cut out a bit larger right here. And so a stressor, or even an internally timed diurnal trigger, will activate the CRH from the hypothalamus. That will go to the pituitary gland and signal release of ACTH, adrenocorticotropic hormone. And that travels to the adrenal cortex here and stimulates the release of glucocorticoids and DHEA, which acts as a counter-regulatory hormone. The very presence of the increased glucocorticoids causes a negative feedback loop here, and that suppresses further production of ACTH and CRH from the hypothalamus and pituitary. This slide gives a great overview of some common causes of high cortisol, and it's important to point out that an elevation in cortisol could be related to a situational trigger and a short-term elevation, or it could relate to a systemic long-term condition and a long-term elevation in cortisol. And it's up to your clinical history to determine which one of those is happening for your patient. Common short-term normal lifestyle triggers are in italics here on the slide, whereas some of the other conditions you can see glandular imbalances, life-threatening conditions, as well as long-term conditions that can affect cortisol release. Similarly, this slide addresses some common causes of low cortisol. Glandular insufficiency from a variety of situations can result in low cortisol, either acutely or chronically. And corticosteroid use, either long-term or recent withdrawal from, is a culprit commonly with low output of cortisol. Any form of repeated long-term stress as well, either physical like an infectious process or psychological, which could include early traumatic experiences or chronic burnout, chronic job stress, they can also result over time in low output of cortisol. Next, we'll shift our attention to cortisone, which is the second glucocorticoid that we measure on the saliva test. Cortisone is considered to be the inactive form of cortisol, or a hormone precursor or reserve for cortisol. Cortisol is converted to the inactive form by 11-beta-HSD2, and you can see on the picture below that 11-beta-HSD2 and 11-beta-HSD1 help interconvert back and forth between cortisone and cortisol. The function of having an inactive form is largely for protection of delicate tissues from excessive cortisol stimulation. And for example, in the renal tissue, by converting to cortisone, it avoids mineralocorticoid excess symptoms that would cause sodium retention, hypertension, and hypokalemia if there were excess stimulation in the renal tissues of too much cortisol. Generally, levels of cortisone and cortisol trend together. Salivary cortisone has been found to be strongly associated with serum cortisol levels. However, in some situations, cortisone is a little bit more accurate to test, and those have to do with when systemic levels of cortisol are either very low or very high. And one example of a situation where the cortisol levels would be very high would be during hydrocortisone therapy or acute stress situations. Because Vibrant tests 4 times a day output of cortisone and cortisol, it enables us to have the values to chart the diurnal rhythm of output of cortisone and cortisol as seen here. And these graphs are helpful because it's not just that we can plot them and take a look at them visually, it's that the actual shape of the curve has been researched. And there's research associations with particular shapes of this curve that are helpful for us as providers. And the most commonly studied variation is a flattened or blunted slope, as seen in this image on the right. And this type of research has been done more with cortisol than cortisone, but I wanted to show you what that pattern looks like. And this type of pattern with cortisol is seen in patients after a significant period of prolonged stress. And some examples of that would be caregiving for a long period of time, or early traumatic life experiences can cause this for many years, burnout. And so you see with that, there's a dampening of steroids released throughout the day. And in this green box on the left, you can see the conditions that has a research association with that flattened output of corticosteroid release throughout the day. So things like inflammatory dysregulation, chronic fatigue, noteworthy that breast cancer mortality is higher in folks with a flattened slope, obesity, depression, cardiovascular disease, and it can be caused by recent withdrawal from corticosteroid therapy or associated with this. So the useful thing for providers is that if you're thinking that you're just treating depression or cardiovascular disease, you may be able to target it a different way by offering adrenal and HPA axis type of interventions to more fully support the patient. Now that we've reviewed all the analytes on the test, let's turn our attention to some frequently asked questions to our clinical team. One interesting question we get from providers is, do the free serum hormones that you test, like free serum testosterone or free cortisol, do they exactly match free salivary hormones? And the best answer for that at this time is that there's a correlation rather than an exact match. Regarding testosterone or free testosterone, there are studies showing a modest association and a strong association between salivary measurements and free serum measurements. However, there are many variables that will affect that association. Some of those are gender and age, as well as the method of salivary collection in the study, as well as how they calculated the free serum testosterone. They can affect the result. So there can be some differences in that regard regarding how they studied it. Similarly, cortisol has strong associations with serum-free measurements. However, we know that the enzyme 11-beta-HSD2 is in high quantity in the saliva gland and in the saliva. And that's the one, if you recall from a few slides ago, which converts the more active cortisol to the precursor cortisone or inactive cortisone to reduce glucocorticoid receptor activation. So because there's a lot of conversion happening in the salivary gland and the saliva, the overall result is that the hormone content is less in salivary output than in serum. Nonetheless, there's a strong association with free serum. Second, what are the limitations of this test? The first limitation is that this is not the preferred method to test when using HRT in sublingual suspension or troche lozenges. This will directly contaminate the salivary reservoir with HRT and cause inaccuracies in the test results. So if your patient is on a sublingual delivery form of HRT, it's best advised to use a different test. Second, this test does not measure metabolites to evaluate estrogen and other hormone. So if you have clearance or metabolism questions you want answered, the urine hormone is the best test for this. Third, the diagnosis of some endocrine conditions relies on total hormone levels, not just bioavailable levels. So serum could still be the best test for diagnostic purposes in those patients who require an initial diagnosis. One example is hyper and hypoandrogenism. Further, potential interactions with food, drinks, or blood from recent toothbrushing can throw off the test. You must avoid those and follow the collection instructions carefully. And last, keep in mind it can be difficult to collect enough saliva in patients with poor salivary flow. So if that's an issue for your patients, then another test would be advised. What tests should you consider as companion tests to the salivary hormone test? Some of the tests listed here are for initial consideration or endocrine diagnostic purposes. The serum hormones can provide luteal phase, ovulation, and other helpful information, whereas the cortisol tests would be indicated for further workup for primary adrenal insufficiency. Thyroid panel and CMP are helpful to assess thyroid function, as well as liver, gallbladder, and renal tests might in fact impact hormone clearance. Urine hormone tests are helpful if your estrogen levels are high on a salivary test, because it can provide metabolites to assess risks of the estrogen metabolism pathways. Looking at the wheat zoomer and the gut zoomer next can be helpful to evaluate factors in the microbiome that affect hormone levels. And the two terms under gut zoomer refer to the estrobolome and the endobolome. And the estrobolome here regards specifically estrogen metabolism and health of the gut microbiota, as you can see in the term estro, whereas endobolome is a proposed term that refers to bidirectional relationships between gut microbiota and steroid hormone metabolism as a whole. But within the gut zoomer is the beta-glucuronidase test, as well as other species involved in dysbiosis, which is helpful as a potential cause of excess estrogen in the body. And the mechanism for that is conjugated estrogens excreted in the bile can be deconjugated by bacterial species in the gut that have beta-glucuronidase activity. And that deconjugation is a reaction in which the estrogens become unbound, leading to estrogen resorption back into circulation from the gut. That's also known as enterohepatic circulation of estrogens, and that can increase estrogen levels. And so those tests can assess for that. And within the wheat zoomer test, you can test LPS, which is linked to progesterone levels. And LPS, or lipopolysaccharide, is also known as endotoxin. And what that is a large component of the outer membrane from gram-negative bacteria, such as E. coli. And they found that elevations in this are linked to dysbiosis, as well as intestinal and blood-brain permeability and corresponding systemic inflammatory effects. Other tests that you could use to a companion to the salivary hormone test would be a total tox burden. We know that environmental toxins, heavy metals, and mycotoxins can all contribute to endocrine disruption. So that may be useful to evaluate. And then the NutriPro or methylation panel can test genetic polymorphisms, which may lead to estrogen metabolism issues as well. Last, we'll take a look at a case study, which will combine all of these factors together and help convey the clinical relevancy. Our patient profile for this case is a 45-year-old female patient. She has regular menstrual cycles, and she was tested in the luteal phase. She's not currently taking any hormones or any medications, and she has symptoms of fibrocystic breast disease, PMS, and reports increased stress at home and at work. So here's the test results for our 45-year-old female, and this section regards the sex steroids. And we can quickly see that her estradiol and estrone are elevated, her progesterone is low, and her PG to E2 ratio is low. So looking closer at her estrogens, the estradiol is significantly higher than the reference range at 1.8, whereas the estrone is just a little bit higher than the reference range at 4.7. The patient's not taking exogenous estrogen, so I would advise exploring other causes for those estrogen elevations for this patient. And as we mentioned earlier in the presentation, some causes of elevated estrogen can be aromatase activity that's increased, chronic liver disease, hyperthyroid, dysregulated gut microbiome, or ectopic production of tumor. So there's more listed in our salivary hormone interpretive guide, which is a great companion to all your test results in our education portal. Next, we can see her progesterone level is low, coming in just under 5, and decreasing progesterone in a female over the age of 40 is not uncommon, but other causes could be irregular or anovulatory cycles during breastfeeding, for example, or perimenopause, PCOS, aging, thyroid disorders, obesity, overexercise, hyperlactin, some long-term use of NSAIDs, endometriosis. There are other causes here as well to take a look at. Regarding the ratio, it's easy to see that the elevated E1 and E2 and the reduced progesterone contribute to the low progesterone, or what would be termed an estrogen dominant result there. And correcting for the estrogens and the progesterone should normalize that out. Regarding her androgens, the testosterone and the DHEAS are within the normal range. However, the DHEAS is a little bit high in the reference range, and that could be explored by asking about any androgen excess symptoms in the patient. Moving on to cortisol, her salivary cortisol shows elevations in the morning and in the noon values here, and both of those contribute to this pooled value also being high. By the evening and the night, those values have normalized for her, and the cortisone values are all normal. Elevated waking values can specifically reflect depression, early stages of burnout, pain, glycemic dysregulation, or job-related stress. Sleep apnea that's severe or different patterns in insomnia can also contribute to irregular morning values. Noon values that are high could just reflect that it's trying to come down into the normal range after the morning elevation, or it could also reflect job stress or daily situational stress. Here are some situational triggers to always consider for irregular cortisol values. We mentioned things like glycemic dysregulation. We also mentioned stress, but other factors like caffeine, cigarette, or drug intake can cause those to be elevated. Exercise, commuting, pain, inflammation, and chronic depression and loneliness can also be a factor in irregular values. Bringing it all together, this test gives us several therapeutic directions that or helpful for the patient. First, it tells us there's a need to balance higher estrogen and lower progesterone levels for this patient's long-term optimal health. Second, it gives us an opportunity to explore and correct metabolism issues related to elevated estradiol, on whether clinically we find that that's related to microbiome or liver health or aromatase upregulation. Identifying which issue is relevant and correcting it is clinically meaningful for long-term prevention of other health sequelae, and as well as for more optimal health currently for the patient. Third, the saliva test identifies a trend towards elevated cortisol, and working up whether this is a situational trigger or it overlaps with a chronic health issue provides a new treatment direction. And it also underlines the importance of addressing stress with patients. A lot of times patients will report stress, but practitioners don't always treat it directly. So here's a biomarker of that stress that you can target and offer an intervention and then reassess. That brings us to the end of the presentation. Thank you for your attention, and I wish you the best outcomes in utilizing this test with your patients.